evidence-based medicine. And in that, we'll look at rationale of therapeutic drug monitoring as it applies to evidence-based medicine. Now, when we talk about evidence-based medicine, it takes into consideration three things, and it integrates the patient values because the patient knows what is important for him or her. It also takes into account best research evidence. And research can be done by epidemiological studies. However, today we might not go to epidemiological studies. I will have another time to look at that. Other than best research evidence, the third area that is integrated in EBM is clinical expertise. And this is where therapeutic drug monitoring comes in. And as lab personnel, we have a role in conjunction with pharmacists and medical doctors that we must play in ensuring that we individualize therapy. Having said that, the purpose of what we are calling evidence-based medicine is to assess the evidence and the risks and benefits of ordering diagnostic tests and treatment. And in medicine, you must weigh the risk and the benefits before you perform certain procedures. Number two, you want to predict if the treatment that you give to your patients will do more harm than good. And I believe all of us did ethics, and you know the principle of beneficence and non-maleficence. The third thing that you do in evidence-based medicine is you encourage dialogue between patient and doctor so that patients can share and make their preferences known to the clinician. Now, therapeutic drug monitoring is one of the areas where you can apply issues of evidence-based medicine. And when you talk about therapeutic drug monitoring, is measurement and interpretation of principally, when I say principally, I mean is not only blood. So it's principally blood or serum drug concentration. Now, by doing this, what are we aiming at? One, we want to optimize patients' drug therapy. And to optimize is to mean that the drug that you give the patient will not be subtherapeutic and will not be toxic. Number two, the more you optimize the drug therapy, you also improve the clinical outcome. And when you improve the clinical outcome, the patient stay in, if it was, he was hospitalized or she was hospitalized, it will be shorter. Thirdly, we want to minimize the risk of drug-induced toxicity because drugs beyond the therapeutic level, the clinically accepted levels, will become toxic. Now, when you do therapeutic drug monitoring, you want also to make sure that the drugs that you are giving to a patient are maintained at concentration within what we call therapeutic window. Then lastly, because different patients have different genetic makeup, and also they have other factors that influence their response to drugs. When you do therapeutic drug monitoring, because it will be individual based, it will also individualize dosage without generalizing. Let's look at objectives of TDM. Number one, you do TDM to attain rapid and safe concentration of drug within therapeutic range in order to provide the safest approach to optimum therapy. Number two, you want to coordinate clinical pathology, pharmacology. You want to coordinate pathology. You want to coordinate chemistry. You want to coordinate toxicology and clinical chemistry together with medicine. Then finally, you want to remove what we call empirical trial and error approach. And most of the treatment that is done locally is not as empirical treatment, where the doctor listens to your symptoms, gives you drug without taking into consideration what your body can take and what can be toxic and what can also be subtherapeutic. Having said that, I want to introduce the principle of therapeutic range. Now, when you talk about therapeutic range, it is the concentration of drug in plasma where the drug has been shown to be efficacious without causing toxic effects in most people. So therapeutic range is just like our reference range that we establish in normal population or healthy population. And we also perform it in the same way. Now, if you give a drug, normally drugs are given in doses. Between the third and fourth dose, the drug goes into what we call steady state. No, around 50 dose. The drug goes into what we call steady state. And it is at this steady state when you should do therapeutic drug monitoring. Below these therapeutic range, we have subtherapeutic range. And when you talk about subtherapeutic range, the drug is not producing maximum effect. And therefore, that's why we give several doses so that the drug can become therapeutic or therapeutically effective. Above this therapeutic range, the drug again becomes toxic and it goes to what we call toxic range. And what I wanted to introduce here is a principle of steady state. After 5 doses, when you look at that this graph, you can see it looks like a plateau. This is the time when drug monitoring should occur, because at this state, for those who did pharmacology, it has undergone absorption and distribution. And therefore, the drug is producing its effects in the tissues or in cells. Again, just to explain the principle of therapeutic window, we have on one side drug effect and time. We are saying it takes time before or a drug can produce effects. And that's why you give several doses. A drug will reach its maximum effect, and at its maximum effect, the process of absorption and distribution has already taken place, and therefore, now we are metabolizing the drug and also excreting the drug. Now, some drugs, for some reasons that I will share, will reach the peak effect and will even move higher, because some of them might be are highly protein bound, and these dynamics might change, and the protein binding might be affected, and therefore the free drug, which is pharmacologically active, will be increased, and that's why we need to do some monitoring. Having said that, let's look at what it entails, to monitor drugs. Now, when you're monitoring drugs, it starts with a decision. Remember, in biochemistry, we usually say it starts with a clinical question, which requires a biochemical answer. The decision to request for the drug level will therefore be due to a certain clinical question. Then after that clinical question, the lab will be required to take a sample. The sample, as I will enumerate, will involve mostly plasma, blood, can involve saliva or urine. Then after the biological sample has been chosen, then it comes to the issue of request. The request should detail at what time of dosing interval should the TDM be performed. Then after the request, it comes to laboratory measurement. Here is where you do all the quality control measures to ensure that your lab results are accurate as much as possible. Then there'll be communication of these results by the lab. Drug reporting is slightly different from the rest of reporting, because one of the things that should happen is that the previous results should be there, and we'll enumerate more about that. Then finally, clinical interpretation. The clinical interpretation of TDM will take cognizance of the patient's condition as per that time that the drug is being monitored. So you don't just look at the amount of drug, the volume of distribution of that drug, but you look at also the clinical condition and make a judgment depending on the clinical condition. Then finally, after the clinical interpretation has been done, there is a therapeutic management. Therapeutic management will even involve things like adjusting the dosage, because now after doing TDM, you will know how is the drug level. Does it mean, is it tending towards toxicity? If it's towards toxicity, you reduce the dose. If it's subtherapeutic, you slightly increase the dose. Now let's start on looking at the decision to request. When does the clinician request for TDM? And we can also call them indications for TDM. Number one, TDM is done for drugs with narrow therapeutic index. And what I mean by narrow therapeutic index is the difference between the toxic dose and subtherapeutic dose. The therapeutic window is small. Drugs like digoxin, which is used for as an antiarrhythmia, will have short therapeutic index. Drug like lithium, which is antimaniac, normally has short therapeutic index or narrow therapeutic index. Aminoglycosides, drugs like gentamicin that we commonly use in our hospitals, they have narrow therapeutic index. So as laboratory people, you must advise our clinician. Number two, it can be due to therapeutic failure. You are giving drugs, and especially for epileptics, and somebody is still getting seizures. The drug that we monitor mostly is phenytoin and sodium taurate. Other drugs like antidepressants can also be monitored. Some drugs have wide variation in metabolism, and there are drugs that exhibit significant metabolic variability and clearance. And these include drugs like warfarin. Warfarin is normally highly protein bound. And another drug is cyclosporin, which is given as, as an immunosuppressant. There are some drugs which have poorly defined clinical endpoint. You don't know when the drug is working or when are you supposed to judge the drug? What is the clinical endpoint? One drug that as such is tacrolimus that is used to prevent kidney rejection. And therefore, you must monitor tacrolimus so that you avoid kidney to be being rejected. The other issue is when drug has suspected toxicity. You want to diagnose or prevent toxicity. Some drugs will have some toxicity, such as aminoglycoside. Aminoglycosides will produce what we call neurotoxicity. And another drug which is used as bronchodilator in asthmatics, known as theophylline. Then the other problem is non-compliance. People will not take drugs very well, and especially antipsychotics. People with given antimaniacs will tend to refuse to take drugs. Therefore, they should be monitored, as well as people with epilepsies who are taking phenytoin. The other problem that will make monitoring necessary is drug interactions, and this includes drugs like warfarin and some antiretrovirals, which will interact with other drugs and cause pharmacokinetic or pharmacodynamic drug interaction. This drug interaction can increase the available drug in serum or plasma, or they can also reduce. Then the other problem that indicates you do drug interaction is physiological changes. There are so many changes in pregnancy, in when you have renal impairment, and when you have hepatic impairment. Remember, cytochrome P450 is produced in the liver, while the renal system is a major organ for excretion of drugs. Now, in which condition is TDM not useful? One, if the clinical outcome is not related, is unrelated to either dose or drug concentration. You don't need to do TDM if clinical outcome, if the concentration will not relate to the clinical outcome. Number two, if dosage need not to be individualized, there are drugs that can be taken left, right, and center, because regardless of individual variation, it will not affect them adversely. Number three is if the pharmacological effect can be clinically quantified. How is the patient? Can the patient's behavior or characteristics represent the pharmacological effect of that drug? When concentration effect relationship remains unestablished, if the concentration and the effect of drug cannot relate, then there are drugs with wide therapeutic range, which you can give, which have a big window where you can use the drug without producing toxic effects. Now, having said that, let's look at what are the biological samples for therapeutic drug monitoring. As I said, plasma is the most, or serum is commonly used. But then, for patients undergoing transplant, we usually use whole blood to measure cyclosporin or tacrolimus. We use urine to measure antidepressant, which we call benzodiazepine. We use sweat to measure drugs of abuse, including cocaine and heroin. We use saliva to measure marijuana, cocaine, alcohol, and lithium. We use breath, and it has been used widely in our rods to measure alcohol concentration in what you have, the amount of alcohol you have taken. Then we can also use air to measure heroin and cocaine. So those are the samples that are commonly used in therapeutic drug concentration monitoring. The other thing was the request. This is how a request for TDM looks like, and it will be slightly different. It is normally slightly different from the rest of request forms. And it has the patient name, the date when the request was made, the hospital number, it has the age, the sex, the weight, the height. These are things that you might not find in most of the other requests, because this sex, weight, height have more to do with, there are some factors that affect drug absorption and all that, pharmacokinetics. Then the drug level requested. Which drug are you requesting? You must indicate there. You must also indicate request for reason for request. This includes reasons like the indication that we have just mentioned. Is it due to suspected toxicity? Is it due to, or you want to just confirm therapy, whether the patient is taking the drug? Do you want to see compliance of the dosages? Do you want to see absence of therapeutic response? Now, the other thing you do is you tell the lab person when should you do the drug monitoring? Is it within the 24 hours? Is it after dosage? Is it after 1 to 2 hours after dosage? Or is it immediately you give the dose? As we'll see, when you test the dose immediately after administration, you are trying to see whether the administered dose is already toxic at the time of administration. Then you need to tell the time and date of the last dose to the person who is monitoring, so that he knows when was the last dose taken. You also need to tell the person the route of administration. We know different routes will have different bioavailability. If you give it IV, it will have 100% bioavailability, the same as IM. But if you give post-oral, remember, there are issues during digestion where some of the drug will be destroyed. Therefore, you must mention some of those things. Then you need to tell the person who is testing, this drug level is for trial. Trial level is the lower level before the next dose is administered. Or is it the peak, the highest level of a dose? Then you need to tell the person mentoring, because of interpretation, whether the patient might have an organ system damage. We said it can be renal, it can be hepatic, it can be cardiac, it can be gastrointestinal, it can as well be endocrine. These organs have a role to play in drug metabolism. You need to tell us which other drugs is the patient taking, because we know drugs can have what we call drug interaction. And we as you will see, most of the patients who are monitored are doing what we call polypharmacy. They are taking more than 5 drugs. Then finally, you need to give an interpretation and sign off the request. So this is how a TDM request looks like. Then after you get the request, you will do sample collection. Sample collection, as I said, can be done at trial level. And trial level is just before the next dose. Then you can also do a peak level, and this is shortly after dosing. And this depends on drugs, pharmacokinetics, absorption, distribution, metabolism, and excretion. So that is what will guide you on what time you get the sample. Now, the next thing that you'll do, is laboratory analysis. We have several immunoassays that are used for drug analysis. When you talk about immunoassays, you know there are things we call PETNIA, there's EMIT, there is radio immunoassay. So they cannot be used for drug assays. It's one of the most sensitive technique. Number 2, you can use high performance liquid chromatography, which is a happy task because this equipment is slightly expensive. You can also use mass spectrophotometry, which is also an expensive equipment. Then after sample collection, the next step will be interpretation. And when interpreting drug concentration, as I said, you must consider patient's clinical condition, the dosage regimen, the age, and other factors, including hepatic function. Then after interpretation, what follows is now the management of the patient. The management of patient means that you will consider dosage adjustment. Based on the drug levels and clinical response, the dosage may be adjusted either upwards or downwards so that you achieve the therapeutic range. This is just a flow diagram explaining how you manage drug therapy using plasma concentration. You must have previous results so that as you interpret the current report, you interpret it on basis of previous results so that you can take a clinical action. The other thing, drug monitoring is a continuous process because most of these people have chronic conditions. Therefore, that's why you can see the management is continuous. So just a few information about protocol for therapeutic drug monitoring as we finalize. One of the things you do when you are monitoring therapeutic drug is patient assessment. You do clinical assessment, and in clinical evaluation, you look at patients' clinical conditions, medical history, and current medications. So that as you make, before you make a request, you have that information in mind so that you know which drug to request and might one drug be interfering with the other one. Number 2, you check whether the patient has indications of TDM that we just mentioned earlier. And if there's need, then you can go ahead and do TDM. The other thing is you do drug selection. From the drug that the patient is doing, you can know which might be causing toxicity. Select the drug that you think might be causing that toxicity and subject it to drug monitoring. Put it in the request that I just presented earlier. Sample collection, as I just mentioned, the timing depends on pharmacokinetics of the drug. It can be trough levels, it can be peak levels, as I've just mentioned. Then, the other important factor is sample handling. Remember, drugs are chemicals. They will undergo degradation. So, as much as possible, prevent degradation or contamination. This can be by way of preservation. Where necessary, use appropriate anticoagulants. Then finally, and this anticoagulant is when you are using blood as the. Then finally, you can also do timely transport to the lab because time in testing is of essence. Most things undergo some. Remember, there is a lot of metabolism that is also taking place during that time, and drug metabolites might not be detected by our testing systems. I don't know whether I'm going back. No, laboratory assessment, as I said, they must be reliable and validated analytical techniques. And I believe you know what validation is. You must validate the techniques that you are using and make sure they are working as per the manufacturer's recommendation. The techniques that I had mentioned, those techniques. The other thing that you do is quality control. And this is just to ensure that the accuracy and precision of your results can be defended. And this will include use of control samples and calibrators. So you must do proper quality control because when you give the wrong results, then you can know what will happen to our patients. The other thing is you have to do pharmacokinetic assessment. And one of the things that you'll be doing when you are doing pharmacokinetic assessment is interpretation of results. And when interpreting results, as we said, you consider patient's clinical condition as much as possible. Dosage regimen, the age of the patient, the weight, and hepatic function. The other thing you look for is pharmacokinetic parameters. And by this, because you have now the drug concentration, you can easily calculate the other relevant pharmacokinetic parameters, which include half-life. Half-life is the time taken for the plasma concentration of a drug to reduce by half. The clearance is the time taken for the amount of drug cleared from plasma per minute. So the amount of drug cleared from plasma per minute, I believe we did urea clearance. And there you need the urine and you need the plasma. The other thing is volume of distribution. When you talk about volume of distribution, we just mean you divide the dose over plasma drug concentration. So because after you do monitoring, you will have plasma concentration, then you can calculate what we call VD. You can also do clinical interpretation. And in clinical evaluation, you assess the therapeutic response. And in this assessment, you just consider both efficacy and potential adverse effects. Then when you do clinical evaluation, you can now adjust the dosage to achieve the desired therapeutic requirements. Then finally, you need to do documentation and communication. As the lab person, remember you are the one who has done the lab work. Remember to communicate and keep proper records, because proper records are essential in drug monitoring, because we need to know the last time what levels of drugs did the patient have. So communicate, keep records of patient details, drug levels, dosage adjustments, and clinical outcomes. Then communicate TDM results to a healthcare team and as well as the patient. Then you can do a follow-up by doing what you call continuous monitoring for drugs which have narrow therapeutic indices. And this includes those with fluctuating patients with fluctuating clinical conditions. Then finally, you can do reassessment. And when you reassess, you can adjust the monitoring frequency as needed. Either you increase the monitoring frequency or reduce depending on the condition of our patients. Then I think this is repeated. Finally, what are the challenges that we have in our countries in performing TDM? Number one, limited infrastructure. We don't have enough facilities that are able to do TDM. Infrastructure includes equipment. Number two, we have high costs. These equipments are very expensive. So maintaining this equipment, acquisition and the maintenance is a nightmare. Number three, there's a problem of highly trained personnel, and therefore there is need to improve our education systems so that embassies can be on drug, can also be done on drug monitoring. Number four, we don't have enough commercially available test kits for commonly measured drugs. Number five is that in the tropics, we are using alternative systems of medicine together with contemporary medicine. And this can bring a challenge of even if we do TDM, these alternative medicine might be competing for the same receptors. So we'll not be sure. And most people tell you take this one together with contemporary medicine, and it can be a challenge. The other thing is that priority is given to tropical diseases. Most of them are nutritional deficiencies. Most of them are diagnosed late, but then they are the priority of even our budget is more on tropical diseases. Then the other thing is there will be ethnic differences which affect pharmacokinetics. So even if you come up with reference ranges or therapeutic ranges, they might be different from between different ethnic communities. Then there is lack of external quality assessment or quality control in most of these drug assays. Most of drug assays depend on external quality assessment, which tends to be very expensive. Then finally, the quality of medicines that we have will and generic formulations give a lot of problems when you are because these formulations are not properly made, and therefore they might not give you correct TDM. So these are some of the challenges, among others, which comes with TDM in developing countries. Sorry. In conclusion, the drug concentration is not complementary and not a substitute to clinical judgment. So treat individual patients and not the drug value. So that's why I said, as you do drug concentration measurement, you must also consider the individual presentations. Does he have the signs of toxicity? So that, because we are saying here, we are just individualizing therapy. Number two, drug concentration may be used as surrogates for drug effects. So this monitoring may just assist with individualization of dosage. It can also be used to detect toxicity. So drug monitoring should be considered to benefit patient management and improve clinical outcomes. And finally, careful selection of drugs should occur. Regular monitoring of drugs is not required in a clinically stable patient. Remember, drug monitoring is an expensive venture, and therefore, if the patient is clinically stable, there is no need of drug monitoring. That's the end of my presentation. Back to you, Ada.
Thank you so much, Dr. Ari, for this wonderful presentation that you've given to us. I hope you're able to hear me well.
Yes, I can hear you.
Yeah, thank you. Now we want to look at the questions that our participants have asked, and so we are also encouraging our participants to continue bringing in more questions so that we can tackle them. And so we want to look at these questions. And one question that we'll start with is from anonymous attendee, and he or she is asking, enlighten us on these terms: drug interaction, drug tolerance, and drug dependence. Over to you, Dr. Ari.
The third one was?
Enlighten us on these terms: drug interaction, drug tolerance, and drug dependence.
Thank you, Ada. When you talk about drug interaction, this is when you give two drugs concomitantly or together or in a short succession. Drugs will tend, one drug can influence the effect of the other. It can increase the effect, or it can reduce the effect of the other. Number two, when you talk about tolerance, is just the ability of the body to take up certain amount of drugs without causing toxicity. Now, when it comes to dependence, it is common with the drugs of abuse. And this is whereby somebody has craving for certain drugs. And this is common with these drugs we call antidepressants. People will have craving just so that he gets that feeling of highness. That's what we call drug dependence. Thank you.
Thank you. Another question from Martin Juguna. He's asking, explain the term therapeutic range.
Okay, when we talk about therapeutic range, this let's look at it synonymous with our clinical lab value, which we call normal ranges or reference ranges. In pharmacology, therapeutic range is just equivalent of reference range in that it is the range along which most of the patients will tolerate the drug. The drug will not cause toxicity, neither will it be subtherapeutic. It is efficacious. So this is the range at which drug is efficacious for majority of the patients.
Thank you. Irene Chebet is asking, which sample is used to test a person taking bhang and tobacco?
As a side, for things like bhang, you can use things like, I think, urine. You can also use, you can even use saliva for some of these things, but not blood.
Okay, thank you. Another question from Thomas Odera, and he's saying, thanks my former lecture at KEMU. I'm getting you loud and clear. The quiz is drug resistant testing part of TDM?
Drug resistant resistance testing cannot be considered part of TDM. Cannot be considered as part of TDM because this is an in vitro, is more of in vitro procedure where the drug interacts with the bacteria outside the body. There are some changes in the conditions, and therefore we cannot consider these TDM.
Yeah, thank you. Another question from Lawi Mwangombe, and he's saying, good presentation, Mwalimu Mbithe. He taught me at KEMU. Please name some antibiotics with narrow therapeutic index.
Okay, the main antibiotics with the narrow therapeutic range are known as aminoglycosides, and they includes the one that include gentamicin, amikacin. Those antibiotics with acin. Mostly gentamicin is the most important aminoglycoside.
Yeah, thank you. Another question from Naomi Kilonzo, and here it goes. What are the strategies that can be implemented in the laboratory to enhance the accuracy and the clinical significance of therapeutic drug monitoring, particularly for drugs with narrow therapeutic ranges and in patients with conditions like renal or liver impairment? Also the risks and the mitigation measures to ensure accurate results. Thank you.
Now, one of the things that we have to do is, first of all, to increase the training of personnel on issue of therapeutic drug monitoring. Number two, increase the number of labs participating in therapeutic drug monitoring so that we can participate in proficiency, external quality assessment or proficiency testing to ensure that the results that we are getting are accurate. The other thing is for patients with liver diseases, we must, I think the most important thing is to create a lot of awareness, because even the clinicians themselves do not know that the therapeutic TDM is important to be done. Therefore, the most important thing is, one, to encourage from wherever we are working, to encourage the employer to start TDM. Two, to increase the number of people who are well trained to perform TDM. And then to participate in external quality assessments so that we ensure that we are within the testing, we are testing well. Thank you.
I think another question from Lawi, and it goes,
Yes.
Please comment on importance of having pharmacology in our medical laboratory syllabus, especially at diploma level where they are not taught, hence become half-baked in the dynamic scientific world.
Thank you, Lawi. I think as you have heard with this therapeutic drug monitoring, the knowledge of pharmacokinetics and the pharmacodynamics is very important. Is very important because it is these two that will determine the drug concentration at any level, and knowledge of especially pharmacokinetics will inform you at what time has the drug been fully distributed, because that is the time that that you must do TDM. So if you don't have knowledge of pharmacokinetics, then it will be difficult to establish at what time as the drug reached steady state. And therefore, you can say this is the time to test certain drug and not the other way around. So it is important, Lawi.
Thank you. Nzioka Mugunti is asking, what is the importance of the height of the patient in a request form?
Remember when you will be at one time be required to calculate the surface area or the volume of the patient. Remember, drug distribution depends as an issue to do with the body mass. The body mass includes the height, the breadth, and all that, and also the weight. So I think the height might not be so important, but there are calculations that you might be required to use the height. And some of them are things like clearance. When you are looking at clearance, there are some formulas that you might need to use the height. Thank you, Ada.
Yeah, another question. How do we circumvent the challenges of doing TDM so that we can have it endowed in our clinical practice?
One of the things that we need to do is to influence the policymakers, so that TDM is considered part and a parcel of essential tests, and especially for patients with things like renal failure. Most people might not be dying because of the renal failure, might be dying because, or even because of with those with transplants, and you don't monitor the drugs well, they will die because of toxicity. And this will be dangerous. So the issue is the policymakers need to put TDM as part of priority tests that are done on the populace. So it's just the issue of policy, because most of resources are not given to issues of TDM, but they are redirected to tropical diseases to the detriment of TDM.
Thank you. Another question from Anonymous. Can diet affect the TDM?
Diet can affect TDM, but not so much effect, not so much, because remember, these are drugs that we are testing. The most affected are drugs that are taken orally. Those ones can be affected. but the one given intramuscularly or intravenously, they will not be affected so much by diet. But those given orally can affect a bit.
Thank you. James Macau is asking, differentiate between pharmacokinetics and pharmacodynamics.
Okay, thank you, James. When you talk about pharmacokinetics, you look at what the drug does to the body, what the body does to the drug. By this I mean the drug will the body will absorb the drug, the body will distribute the drug, and when I talk about distribution, it will be partitioned between the tissues and the plasma. Then, thirdly, the body will metabolize the drug. We talked about phase 1 and phase 2 of metabolism. Where phase 1, you do you want just to make by metabolism, you want to make the drug less active. You also want to make the drug soluble in water for the subsequent steps of excretion. And then finally, the body will excrete the drug either through the kidneys, through sweat, through breath. Mostly those are the routes, or through the GIT. Then when we talk about pharmacodynamics, we are talking about what the drug does to the body. And the drug will bind to receptors through what we call the law of mass action. And the law of mass action just states that the more the substrate, the more the reaction, until all the binding sites are occupied. And when they are occupied, even if you add more drug, there will be no effect. So pharmacodynamic is now the effect of drug on the sites of action, and that is the cells and tissues. Thank you, Ada.
Okay, thank you. Another question from Anonymous, and this goes, in your own opinion, should TDM be done to patients on ARVs?
Yes, in my own opinion, TDM is an important procedure on patients on ARVs, because people on antiretrovirals, most antiretrovirals will have what we call drug interaction. And therefore, they might become subtherapeutic or toxic because of these drug interactions. The other thing is ARVs are toxic naturally to the liver cells. This damage to liver cells will affect what we call metabolism of drugs, because metabolism of drugs, majority of it takes place in the liver through the enzyme we call cytochrome P450. Therefore, I think it is important.
Thank you. Another question, which is a bit general, but you can guide on how you're going to answer it. It's from Martin Juguna, and he's saying, highlight more on test methodology of TDM. You can explain, maybe you can guide on how you're going to explain it.
Okay. Most of the tests, as I've said, include immunoassays. Now, immunoassays, there are several types of immunoassays. The most common one is known as CLIA. And this one is chemiluminescence immunoassay. And by chemiluminescence, because drug is a chemical, it will react it will just react with the chemicals in these in this test to produce some luminescence. Luminescence is some light. So if it produces light, that light intensity will be measured, and it will be proportional to the amount of drug that is present in that sample. The other test is can be the other one I can talk about is what you call mass spectrometry. In mass spectrometry, the drug is broken down into, is ionized, and it will have a characteristic mass and charge. That mass is taken through a process which starts with ionization, it goes to deflection, then finally there is quantification. And during quantification, it produces certain peaks which are characteristic of certain chemical. Then those peaks will be picked up and related to a library that exists in the mass spectrometer. Then at that time, when you look at what is the library in the mass spectrometer, you can know the amount of drug, the type of drug, and also the concentration. For the HPLC, I don't have a lot of information about it. And thank you, Adam.
Yeah, thank you. And so there's another question here from Agri Mogire, and it says, what's the relationship between TDM and detection of drug poisoning in the lab?
Okay. TDM and the issue of drug poisoning is one and the same thing, because the issue is when you talk about poisoning, it's just the issue of toxicity. So it's one and the same thing. And that's why when we are studying TDM, we study it together with toxicology. Thank you.
Thank you. Thank you. Another question, in TDM, can drug resistance be evaluated and detected early enough?
Drug resistance cannot be detected by TDM, because most of the drugs, some of the drugs that resist are resisting due to issues of mutation. And mutation of drug targets, and therefore it might not be easy to detect them through TDM, because TDM looks at plasma drug concentration, because the concentration of the drug when you do TDM will still be high, but then because of mutation of the target, it will not work. That's why it is not working. Thank you, Ada.
Okay, Washington Dege is asking, can TDM be used to combat AMR?
TDM cannot be used to combat AMR, because most of the drugs that are caused that become resistant do not fit in the criteria for TDM. And I've also said is that it is the bacteria that mutates, and as you target with the drug, because the drug must affect the metabolism in that bacteria, the drug is not able to do that. So the plasma concentration will still be normal. However, the bacteria is not becoming bacteriostatic, or the drug is not bactericidal, or neither bacteriostatic.
Yeah, thank you. Moses Lutome is asking, is methotrexate drug classified as a drug with a narrow therapeutic index or a wide therapeutics index?
Thank you. Methotrexate, which is given for neoplasms, for cancer, is one of the drugs with narrow therapeutic index and is a candidate for TDM.
Yeah. Johnson Owino, in our current practice, there are numerous cases of polypharmacy practiced by most of our prescribers, and taking into account there are chances of drug interactions. What is your take on that, and how can we go about it to ensure safety of our patients?
Thank you. Polypharmacy is a common practice, and what I said as one of the challenges is there is need to create awareness. There's need to create awareness even to our prescribers so that they know some drugs will cause some interactions, and therefore, and even our patients, they need to know that this issue of going to the counter to buy drugs is not allowed, because some drugs might be interacting and causing toxicity, or even reducing the effect of the other drug, which becomes subtherapeutic. Therefore, the issue of awareness needs to be created. Thank you, Heather.
Yeah, thank you. Another question. Can TDM levels for tacrolimus be affected after dialysis for those whose transplanted kidney have not peaked?
The levels of tacrolimus will not really be affected by dialysis. Will not really be affected by dialysis, because when you look at the principle of dialysis, it might not remove drugs. It might not reduce the amount of drugs. The only thing is the amount of tacrolimus when it reduces because of other physiological issues, it can lead to kidney rejection, because this drug is being given as an immunosuppressant, so that it can avoid kidney rejection. So
okay,
I
thank
don't
you.
Be affected.
Yeah, thank you. Another question from Kundu Kennedy, and he's asking, one drug has therapeutic index of 0.8 and the other with index of 0.3. Which one is more safe?
The one with 0.8. Because the higher the therapeutic index, the better.
Okay, thank you. Another question. A client came to me today and requested for lithium levels on her blood. What was the best method I could use to measure it?
For most of our labs, immunoassays are the most common. Immunoassays are the most common. So you can look for the kit for this specific drug, which is an antimaniac. So you can use immunoassays, which can include CLIA, PETICNIA, and all that.
Okay, thank you. What determines a type of specimen collected, e.g., trough or peak level specimen?
Now, what determines the kind of specimen to be collected is the pharmacokinetics of drug. You must have prior understanding of how long does it take for the drug to be absorbed? How long does it take for the drug to be distributed? When does it reach the highest level? So that information on pharmacokinetics is very important, because as I just said, is a drug should be estimated when it reaches its steady state. And in steady state, the distribution and absorption have already taken place, and the drug is already producing its effect on the sites where it's supposed to produce. And that's the time when you can check for the levels. So the pharmacokinetics of each drug should be considered, including absorption, distribution, metabolism, and excretion. Also, when the time when the drug is cleared is also important, so that you are not checking for a drug that has already been cleared from the system. Thank you. Thank you, Ada.
Yeah, thank you. Gladys Ndungu, can you monitor a child who was using digoxin and suddenly stopped 2 years ago?
So Ndungu, I think you cannot monitor a child who stopped using, because the half-life of digoxin is just a day or so. So when you test for digoxin in a child who stopped 2 years ago, you will not likely to get it. So you are just supposed to test to do TDM when the child is actively taking that digitalis. Thank you.
Thank you. What happens when a patient opts to take a QID drug as a BD in double strength dosage, and what's the efficacy?
Thank you. Now, what happens if a patient chooses to take a BD? Is you will affect the drug will not reach the therapeutic window, and therefore, what the patient is doing is getting a drug that is a dose that is subtherapeutic, and this is the major cause for drug resistance for if it was an antibiotic. So the issue is the drug will be subtherapeutic, will not be efficacious if you take it at a lower dose, and therefore it is a cause of alarm. Back to Ada.
Thank you. Another important information we are getting from Josephat Kinoti, and he is saying, great presentation for MedLab officers. To inform us, pharmacology is currently taught at diploma level for MLS students at KMTC. Thank you so much, Josephat Kinoti, for that information. We are well guided. And lastly, let me give our last question because of time. And then I'm giving the last question, then Dr. you'll be able to answer that question and also give your parting shot. And maybe if you have another question from the members that you feel you need to do some clarification, then you can do it as we wind up, because we are finishing in the next 4 minutes. So our last question is from Lawrence Mulavi, and he is asking, is drug tolerance reversible after discontinuation of drug for some time?
Yes, I believe drug tolerance is reversible, because if you no longer take the drug, the receptors will now be free from that drug. So it is reversible. So maybe my final shot is we take our position in the clinical team so that we can guide clinicians. And I've been saying we need to participate in ward rounds so that just like nutritionists go there to recommend on issues of drugs, issues of the food that the patients need to take, we need also to advise our clinicians not only on this issue of drugs, but which tests will benefit patients? Because we have that knowledge, and if it's used well, it will give good clinical outcomes to our patients. So the issue is we need to fight for our space in clinical setup. Thank you, Arthur, for the opportunity.
Yeah, thank you so much, Dr. for this informative presentation that you've given to us. Actually, it's right. We need to fight for our place on matters pharmacology, on matters therapeutic drug monitoring, because we are, as the practitioners in charge of diagnostics, this is a monitoring area for the diseases that are treated in our facilities, and therefore it is important that we take the lead in ensuring that we are able to monitor how the drugs are able to help our patients. This is an area that we haven't really embraced, but as a department, I think it will be in order if we take it seriously. Otherwise, on behalf of Lab Medicine Society of Kenya, we thank all our participants who managed to attend this particular webinar. And we are assuring you that we'll work around the clock to make sure that all your certificates are with you in the next 24 hours. We'll also make sure that we are able to upload all your CPDs as we have promised. We plan to have another webinar this Friday, same time, and we also inform you and let you know that you will be at liberty to do registration so that you can attend the Friday presentation. We welcome you. And once again, I thank you all. And I also thank our presenter today, Dr. Mbidi, for being with us. Looking forward to meet you again on Friday. Ladies and gentlemen, my name is Arthur Imari, and I hope you're going to have a good evening. Thank you.